Welcome. Thank you for joining us. This is the fourth in our series, the Brain Health Perspective series that centers brain health. And we're really conscious about including Pan-African voices in a global vision to support brain health. We have an exciting group of panelists who will join us today, and I will introduce them soon. This forms part of the work that I do with the Africa Brain Health Network. The Africa Brain Health Network is a network, as the name suggests, dedicated to supporting brain health across the African continent in various ways, from helping people living with specific illnesses to looking at how to reduce risk and how to optimize brain function in different ways, and employing different techniques from caregiving to art to neuroscience to research. So we invite you to go to our website and learn more about the Africa Brain Health Network. Very briefly on brain health. Brain health is about keeping the brain healthy, to reduce the risk of certain illnesses, to keep the brain tissue healthy, the gray matter, the white matter, and also it looks at how to optimize brain function. And it considers this across a life course. So it can be quite complex, but within this complexity, we are finding ways to actually support better brain health. Today's webinar is going to focus on neurological challenges, opportunities, and priorities. Neurology is an exciting field, but there's a lot of potential to actually improve access to care, improve care that is given to people with neurological illnesses, and potentially also to reduce the risk of certain neurological illnesses. I'm very excited to be hosting the panelists we have today. Dr. Alejandra Guerrero, Dr. Tina Charway-Felli, and Professor Yahya Choonara. I will introduce each individually before they actually present their topic. And we're going to start with Alejandra. Alejandra is a neurologist from Colombia. She's currently based in Dubai. She has a master's in public health and is also a Global Atlantic Fellow for Equity in Brain Health. Her presentation will look at dementia and challenges and opportunities within a middle-income country, namely Colombia. Over to you, Alejandra.
Okay, so I'm going to talk about my experience in Colombia. Colombia is a middle-income country, and I just want to show that Colombia is part of South America. It's here in the map. It's at the top in the north part of South America. And I would like to tell you something about Colombia. So these are some facts about Colombia. We don't have seasons because it is a country near the equator, and we have sunlight through the year. We produce 60% of the world's most expensive emeralds. It's the only country in South America that has access to both oceans, the Pacific and the Caribbean Ocean. And we have all kinds of landscapes. We have highlands, we have rainforests, we have the Amazon forest, and we have also tropical grasslands. So anything you want to see in Colombia, we have it. It is situated in the famous Ring of Fire. So it's an area that has many earthquakes and volcanic eruptions. And Colombian coffee is also very famous. We are also famous, unfortunately, for the war and crime problems. So I'm sure most of you know the story of Pablo Escobar. He was a cocaine narco, very famous in the 90s, and his business did very bad things to our country. And Colombia is also famous because of the guerrilla fighting. And it's important to talk about this because the toll that this conflict brought to Colombia is huge. This is the number of victims of the conflict between 1985 and 2018. It's more than 8 million internal displaced people. Other 121,000 are disappeared, 50,000 kidnapped, 16,000 children recruited, and 500 killed. So the toll is huge in our country, and this the peace, there was a peace agreement that was signed in 2016, and we are still trying to recover from all this conflict, long-term conflict. And I think if we are going to talk about brain health in the case of Colombia, this is something that we really need to take into account. So right now, the peace agreement is still in the implementation phase. It has been a little bit difficult, but in paper, we are in peace. So as I'm the first to talk about this, I just want to remind the concept of brain health. This concept is new. Actually, this is a position paper that WHO published last year, and here they try to make a definition of brain health, telling us that it's the state of brain functioning across cognitive, sensory, social, emotional, behavioral, and motor domains that allows a person to realize their full potential over the life course. This is very important. It's not only about old people or about adults, even since newborns or since pregnancy, we have to take brain health into account. And it is irrespective of the presence of absence of any disorder or disease. And brain health is also determined by interactions between different determinants in a person individual context. So this is not only about health, this is about economy, this is about politics, this is about social determinants of health. So brain health is about everything, and that's why we cannot approach brain health only from a health system perspective. And if we optimize brain health, this will contribute to a great well-being and will help to advance our societies. There are lots of threats that we have actually for brain health. And it's not only the diseases that can affect people. It's said that 1 in 3 people globally will develop a neurological disorder at some point in their lifetime. And I think it should worry us a lot, because actually some of us can be in that list. So brain health is all around. And it can be affected, but even air pollution, heavy metals, pesticides, solvents, chemicals, as I said before, by the economy, by the social determinants of health. So the burden of these neurological disorders, it's huge. Today I'm going to tell about some facts about dementia. Why we should care about this neurological disorder? Because right now there are 55 million people that live with dementia around the world. It's the 7th leading cause of death, and it's caused by different diseases, not only Alzheimer's disease. And globally, the numbers of people living with dementia will increase from 50 million right now, and it's going to be 152 million in 2015. That means a 200% increase of the number of people with dementia. That's why it's very important. So the challenges I can tell from my experience is that, for example, in the Colombian case, there are no policies directly focusing on dementia. And this brings us to a point where sometimes we feel there's nothing we can do from the public health perspective, because if we don't have the support from the governments, it's very difficult to implement something that can really have an impact in public health. And usually the ones that take care of this issue are non-governmental organizations and research groups from academic institutions. And the problem is that this work usually is done in the local areas, in the universities, in some communities, but we can't go beyond that. Other important thing is that the public policies are not based on the country's needs and characteristics. Usually, the people that write these policies don't consider the cultural, social, and biological diversity of the population. There is lack of awareness and stigma in the case of dementia, lack of access for rural communities. So all the attention is focused on the big cities, and the healthcare providers, like the specialized, are only in the big cities. For the rural communities, there's nothing. Another big challenge is the communication barriers between healthcare workers and the person living with dementia and their families. And this is a huge topic. It has different branches. And this could be because there is lack of time. Some health care professionals only have 10, 20 minutes to explain a complex diagnosis like this, and they have to explain, they have to give treatment, to explain the prognosis, the non-pharmacological treatment. So this time is not enough to approach a disease like this. And it's not only in dementia, for epilepsy, for Parkinson's disease, even for migraine. 20 minutes, 30 minutes is not enough. There's a lack of clarity in the terms used to communicate the diagnosis. There is lack of explanation about treatment and prognosis. And even there is lack of training for healthcare professionals, especially in the primary care levels, where the focus should be, because they are the ones that are going to face or to do the first approach to these neurological patients. And there is not focus on primary prevention, even knowing that dementia in a percentage has some risk factors that can be prevented. What are the opportunities with the COVID-19 pandemic? We learn how to use telemedicine and virtual platforms, and I think this is something we need to take advantage from, because this is the way that we can go to rural communities, that we can train healthcare personnel that are not in these big cities or don't have time or access to go to a university and have more formal training. And it's important that when we want to address dementia, we need to do it in a comprehensive way. The country context needs to be taken into account. We need to identify the needs of people with dementia, the caregivers, and the strategies and all the interventions that we are going to do, they need to be adapted to the characteristics of the country. If not, this is not going to work. And it's important that to approach these diseases, we do a collaborative effort. So as I said before, this is not only a healthcare problem. We have to engage the community, we have to engage research group, healthcare providers, decision makers. It's very important. And of course, the government, they have to understand that this brain health is very important, and we have to approach it at every way. So this is what I wanted to say today.
Thank you, Alejandra. It was a lovely presentation, and I think you showed the complexity of brain health. Like, we have that definition of what brain health is, and now we need to try and center our approaches, understanding both global and local issues as we do this. And I love that you actually included the trauma in Colombia, and the impact that will have on brain health, both from a physical and a psychological perspective, is something we probably need to consider. Like, South Africa has different trauma-related issues that we also need to consider. But also the role of all the environmental toxins, the chemicals, air pollution, and whether we as neurologists or people focusing on brain health need to start including the environmental concerns more strongly as we go forward in terms of brain health. We will have questions for Alejandra at the end. We will now go to the second speaker, Dr. Tina Charway-Felli. who is a neurologist based in Ghana, and she is the current president of the African Academy of Neurology, and is quite passionate about improving access to neurological care. Over to you, Tina.
Thank you very much, Kirti. It is my pleasure to be able to talk to you today. Alejandra said a lot of really important things about brain health, and we do need to see brain health from all different perspectives. So from the beginning, prevention of brain disease, but also when brain disease sometimes inevitably occurs, individuals need to know, one, that there is treatment that is available, there are services that are available, and how do we meet the need to the services, make sure the services are available, and have people understand that here are the services you can approach. So my talk is the road to improving access to neurological care in Africa. I have no relevant disclosures. I'm sure to this audience, there are no secrets that I will be exposing, but it is important to frame the problem based on the African continent. So we know we have 54 countries and territories, and we do consider North Africa to be part of Africa. The population is 1.3 billion and growing. Our population is young. It's mostly in the rural regions, and there is a high prevalence of poverty, which is a very important factor to take into consideration when we're talking about brain health and nurturing brain health from early stages. And a reflection of the challenges that we have include the very high infant mortality rates. At the same time, we are a growing population, and more than 50% of the African population is below the age of 25. With this, we are still undergoing demographic changes, and life expectancy across the continent at different rates is increasing. So we are faced with the challenges of a budding young population whose brain health needs to be taken care of, and the older population who will be developing the diseases associated with non-communicable disease, having carried through the burden of infectious disease, and the other conditions that happen with advanced age. So again, to frame the problem, so this is the treating end of brain health. The neurologist per 100,000 population recommended by the WHO is 1 to 5. And as you can see from this slide, the only country on the African continent that meets that ratio is Tunisia at 1.69 neurologists per 100,000 population. The rest, even on the top 10 of those countries with neurologists, are below the recommended 1 to 5. And then this slide, unfortunately, is even sadder. These are the bottom 10 countries, not including those countries that do not have any neurologist at all. And that brings the average neurologist per 100,000 population on the continent to 0.12. The situation with pediatric neurologists is even worse, and we have 27 countries, that's a little over half, that have no child neurologists at all. And so the care of children with neurological issues either falls on the adult neurologist or the pediatrician with no neurological training. In 15 countries, we have 4 or less child neurologists, 4 countries have 5 to 10 child neurologists, and 3 countries have between 13 and 20 child neurologists, and only 3 countries on the continent have over 35 child neurologists. And this is data from Joe Wilmshurst et al., and this was access to pediatric neurologists and pediatric neurology training worldwide from the International Child Neurology Association Education and Advocacy Working Group. Now, I am the president of the African Academy of Neurology, and we needed to know, as the African Academy of Neurology, what the state of affairs of those neurologists that do exist on the continent. And therefore, we held a survey where more than half of the African continent participated in this survey. And we find, as you can see on the slide, that the majority of the neurologists, that low ratio of neurologists are located in capital cities and other urban centers. And you have to remember that most of our population is still rural despite trends towards urbanization. And even within the capital cities, we do have other bottlenecks where those neurologists that are available in the capital or urban cities are located within tertiary hospitals. That means they need to have been referred to get access to that neurologist. So not only is the neurologist few and far between, but access to that neurology is a problem. And so we have set upon ourselves the task of seeing how we can address these issues. So the way forward is multi-pronged. So it involves research, because if we don't know the numbers, we don't know how we're supposed to solve them, or we need to address the issues, discover what the issues are. And all the different ways forward are interlinked. So one big problem the African continent is facing, especially now, is the brain drain, and is something that we need to halt and reverse. We need to continue training the existing workforce in neuroscience and neurology so that there is greater recognition of neurological issues. We need to increase, of course, the numbers of specialized neurological workforce. And then something without which we cannot function is public education. So we need to get all the different stakeholders in brain health, which is absolutely everybody, from the common person up to the policymakers, the scientists, the educators. We need to get everybody involved in understanding the value of brain health. And so education is one of the ways we're going to do this. We need neurology education for primary healthcare providers, because that's the first person the individual with a neurological problem is going to encounter on their paths. This has to include neurology training for the non-neurologist, again, so that these issues are recognized. Those diseases that have implications in terms of brain health, which is essentially all of them, are also addressed in such a way that brain health suffers minimally as much as possible. And then, of course, neurology for allied health professionals and other health professionals. We've mentioned this already. We cannot get away with neurology training for specialist neurologists, but we do not work in silos. Without the previous three groups that I have mentioned, our work will still be extraordinarily difficult. So there is lots that is happening on the continent that we, the African Academy of Neurology, cannot take credit for, but we're very happy that is happening. And that there are many national neurological training sites in many of the countries on the continent. Some have complete training, some have incomplete. For example, Angola and Mozambique have incomplete training, where part of the training is carried out in another Lusophone countries such as Portugal or Brazil. We have also World Federation of Neurology accredited training sites across the continent, two in North Africa, Cairo and Rabat, one in Dakar, Senegal, and most recently, one in Cape Town, South Africa. Most importantly, again, we have to recognize that we do not live alone in our own silos. We have to collaborate, all different parts of the continent. There are different strengths, different challenges, common challenges across the continent, and different ways in which we have learned to approach our challenges. We need to work together. The world is now a marble, and we are all intertwined. And we also have to bear in mind that whilst we should focus our strengths within the continent, we cannot do without international collaboration, so intra-regional collaboration amongst the global south. So Alejandra told us about the issues that are faced in Colombia, and there are similarities as well as differences in the global south, but we can all share our experiences and grow together. And then, of course, north-south collaboration. Very importantly, and again, Alejandra highlighted some of this, we need to take neurology to where it is needed. There is no point having 20 neurologists inside a tertiary institution with very limited access to them. Neurology needs to go to where it is needed. We need to improve neuroscience education for the general public, neuroscience education in medical school. We need to get rid of this tendency of neurophobia, where everything neurological, people just shut their minds off. Oh, I won't need this. I'll leave that to the neurologist. Everyone needs to be involved. We need to involve medical students in our outreach programs already during medical school, as well as sensitizing primary healthcare to disorders of the nervous system. Again, recognition is key. And this taking of the services to where it is needed. So, of course, we can't expect every neurologist to go to the rural areas, but one, with outreach programs, and then again, the sensitization of primary healthcare providers to the recognition of neurological disease, the gap created by the absence of the neurologist will be reduced. Across the continent, it is important that we have some standardization of neurological curricula and base it on a very nuanced approach. This curriculum has to reflect the peculiarities of our region. So we can't transpose a curriculum that was designed for Europe or designed for North America and expect it to function properly in our region. That's not to say we need something that is substandard, but it definitely needs to take into consideration the disease entities we face and the characteristics, apologies, of those disease entities when they found in our continent, our healthcare seeking behaviors, our cultural, it has been mentioned earlier, our cultural behaviors, and a realistic approach to diagnosis and management. Of course, there should be opportunities for exposure with bidirectional exchange program. So every single level of the population, every single level in medical education needs to be involved as we move forward and promote the idea of brain health. Prevention, improving brain health of the young, nutrition. We need to get everyone involved in that, and our governments, especially our policymakers, need to understand the value of having a population whose brain health is optimum, because then we have a population that is highly productive, and everybody benefits from that, the individual, the society, and the countries as a whole. Thank you very much.
Thank you very much, Tina. Really excellent presentation. And I think many people actually practicing across the continent would so relate to what you were talking about. I worked briefly in a rural part of South Africa, and it was exceptionally challenging for many reasons. But I think also in part our curriculum is not designed for what you actually see in a rural context. So it'll be one of my questions when we get to the question session. We're now going to go over to our third speaker, Professor Yahya Choonara, who is at the University of Witwatersrand, a pharmaceutical scientist who heads an incredible lab whose name I'm going to have to read, the WITS Advanced Drug Delivery Platform Research Lab. But really at the cutting edge of innovation using nanotechnology and others, which really has the potential to change how we manage people with neurological conditions. Over to you, Yahya.
Thank you, Kirti, and thank you, colleagues, for this opportunity to provide some background on the work that we do. A very different perspective to the other two speakers in terms of my focus is more on the therapeutics. How can we patients who obviously are suffering from neurological diseases and disorders, how can we improve their quality of life from a patient-centric therapeutics point of view? How can we get the medications or therapeutics that we use to treat these diseases and conditions to be more safe, to be more efficacious, to have higher quality? And in terms of improving quality of life, we don't mean the actual drug molecule. The drug molecules are known. Most of you are neurologists on this call, and you know how to prescribe and what to prescribe, when and how. But it's more from the formulation perspective. How do we get better ways of delivering these neuroactive molecules into the brain, various regions of the brain, or whether it's the CNS or wherever else CNS is brain, obviously, but anywhere else it is a neurological problem. How do we actually do that in a more affordable way, more accessible way? All of these kinds of questions is the kind of question that I answer with my team at the WITS Advanced Drug Delivery Platform. It's also like, for example, if you look at HIV, for example, now, if you look at the treatment of that infectious diseases, when it just started off, patients had to take daily pills, one up to 4 times a day, every day for the rest of their lives. Now, when you look at the different formulations available for HIV, it's 1 injection per month, or one every 6 months. Just that change in formulation work is managed to improve the quality of life in terms of reducing the pill burden for patients, improving their compliance to therapy. And I think in the neurological space, in neurotherapeutics, compliance to medication is also a very key component to ensure that the quality of life is maintained for many sorts of patients, suffering from whether it's psychiatric disorders, whether it's, infectious diseases in the brain, whether it's brain cancer, all of that. I have a few slides that I will share with you. I'm not going to go into detail on every one. They're quite technical. And I just want to obviously respect the views of my first two speakers, where we talked more on the prevention side. I don't want to give into a heavy treatment side, but I will just share some of the work that we do. So I don't know if you can see my slides. Is it visible, colleagues?
Yeah, we can see them.
Okay, perfect. So the title of my presentation is these brain-targeted therapeutics from a bio-inspired nanomedicine perspective. I'm based in the Department of Pharmacy and Pharmacology, and I have to say that much of this work also has been done in collaboration with the neurology department here at Wits University, which we are very proud to obviously be associated with the Department of Neurology at Wits. If I just got some gremlins with the tech here. Yeah, so this unit was launched in 2007. It focused on this concept that we call advanced drug delivery. How do we get the drugs delivered into the body in an optimal way? It's grown to include a whole lot of work in the area of nanomedicine, functional biomaterials, and regenerative medicine. There we're talking about, if your brain tissue is being harmed in whatever way, brain injury, traumatic brain injury, spinal cord injury, how can we use regenerative medicine to actually regenerate brain tissue or neural tissue or peripheral nerve injury? In terms of nanomedicine, that's the focus of getting neuroactive drugs to target various regions within the brain where they actually become active. And also functional biomaterials is to actually design biomaterials that have neurodurability. They kind of, interface with the neural tissue or in neurological system, and that's how we can use them to actually deliver these molecules to specific areas. We are the largest platform for innovative pharmaceutical science research in South Africa, and we have around about 47 patents in the field. 20% of these are in the area of nanomedicine. So it's got to do with, some neurological application to the nanomedicines and nanoparticles that we design. So we focus on designing the 21st century patient-centric medicines. And I think that's where it's not strictly the brain health by definition as we know it on this series, but, patient-centric medicines goes a long way in trying to improve the quality of life of patients who already have suffering from some form of pathology in the neurological space. So why do we do this kind of science? Because many neuroactives, NCEs, new chemical entities have very low bioavailability. And because of this low bioavailability, you tend to expose the body to more drug molecule, and this ultimately increases the side effects. And then with the side effects, patients don't want to take the medication, and you get the poor patient compliance. Bioavailability, I think most of us may be aware of the term, but in our group, we look at the concept of neuroavailability, because you can swallow a tablet or a capsule and the drug is then obviously absorbed into the bloodstream, but how much of that drug is actually getting into the neurospace, at those receptors and synapses where they actually have to function to release your biochemicals to solve a problem neurologically. So neuroavailability is a big concept that we focus on. Diseases are only optimally treated if there's a proper mode of delivery available. You need to target the exact pathologies, where is actually the disease manifesting within the body, and you get the drugs to act on there. So it's not a side effect and not accumulation of off-target effects. It's very difficult to bring new chemical entities to the market. So there's a lot of exciting new drug molecules that may be available to treat a host of neurological disorders and diseases, but they cannot become to the market if you do not have a proper formulation science, a proper drug delivery system to ensure that these new chemical entities that are promising actually reach the areas where they need to work and to function, the receptors, etc., etc. And also, the question of affordability and R&D costs. The products that are available to patients obviously need to be more affordable, need to be more accessible, and how can we use technology and therapeutics, advanced therapeutics, to actually make this happen and have more contextually relevant formulations for patients. Many new chemical entities require new delivery technologies, like I said, for efficiently target disease sites. and also to decrease the frequency of drug dosing while maintaining the therapeutic efficacy. So instead of taking, 2, 3, 4, 5 pills a day, daily for the rest of their lives, especially for chronic conditions, how can we reduce that by using implants, by using injectable depots, all sorts of technologies that can improve the sustained release or prolonged release of these neuroactives. And ultimately, this will improve patient compliance and make it more user-friendly product technologies for patients. We're also looking at a big, evolution in terms of peptides and proteins and monoclonal antibodies and all of these biologics that are coming onto the market. And these biologics are very expensive, firstly. It becomes an accessibility issue for patients. The issue there is, the stability of these labile molecules. The current technologies are very expensive, and therefore these biologics have to be encapsulated into very fancy injectables that also needs to maintain a cold chain, all driving the cost of these products. So with the advent of peptides and proteins that are used to treat neurological diseases, how can we get better formulation science so that we can make this more accessible? And lastly, we do the science because, R&D drives pharma companies and is responsible for all of these new molecules that come in. I always say that, what's good is a prescription without any products on it. It's just a death sentence because you've diagnosed somebody and now you've got no way of treating them and telling them what to take to solve them. It's better not knowing what they had if you don't have products that can actually now alleviate that problem or try to help or manage the disease condition. So R&D is also very important for pharma companies, and that's why we do this kind of research to try to solve these problems that may be faced at the cold face of the patient. And I think that's where the neurologists come in very valuable to our team, because you see these patients on a daily basis, you understand what is the practical needs on the bedside and how we can move from the benchtop in the lab to products on the bedside. Drug delivery science helps, molecules to become from first in class to best in class. So, you can have first in class molecules. I just use an example of a statin here. You have lovastatin, which is a first in class statin, and everybody knows about it. It has therapeutic superiority, but then atorvastatin is a better one because its therapeutic superiority is because of the better cardiovascular disease outcomes, for example. So that's where you have a move from first in class to best in class. And I think that's the kind of technologies we want to develop, is have the neuroactive drugs that are currently first in class, and how do we make them best by reducing side effects, improving the targetability, making them more safe, more efficacious, and higher quality, improving the safety, and also improve acceptance in terms of patient compliance. So, we use a whole lot of, we've got this slogan of from molecules to medicine. So we use small molecule drugs. In this case, it would be neuroactive drugs. Now, with COVID-19, we saw the advent of nucleic acids, mRNAs, siRNAs, RNA therapeutics, all of these also coming in the neurological space. And how do we deliver these sensitive molecules to various regions within the CNS? Proteins and peptides, I spoke about already. And very critical and central to all of this is the use of what we call biomaterials, or you can term it neuromaterials. So these are materials or excipients that are actually compatible with the neurological space, where neurological tissue, whether it be brain, spinal cord, peripheral nerves, whatever it may be, where we're implanting these devices, they actually are compatible or neurocompatible. In terms of nanomedicine, I'm just going to go through very briefly here. This is the space that we're playing in, as you can see from, the water molecules right up onto a tennis ball. And you can see where the nano fits in, from glucose molecules up to viruses, very small particles that we can use to encapsulate these neuroactive drug molecules within them. So what are these particles? Well, in our lab, we design things like what we call nanolipose shells. So you see the shell there, and inside will have drug. You can have nanowires, nanofibers, nanospheres, bubbles, membranes, nanosomes, all sorts of these nanoparticles, which you can't see visibly. They're subvisible particles. And they are used to obviously encapsulate drug. And the whole idea is to target these, make them functional so that they can target, once absorbed in the bloodstream, they can move across blood-brain barrier or wherever it needs to get to, and obviously target a certain condition that you are looking for. For example, the nanofibers, those may be used to obviously for peripheral nerve disease, peripheral nerve injury, for example, where you can have a nanofibrous scaffold, and that scaffolding can be used to seed cells, neurological cells, that can obviously help regenerate peripheral nerve, or it might be spinal cord. So that's why we have the different archetypes of different shapes and geometries of these nanoparticles that can be used as nanomedicines. These are just some of the equipment available in our lab to do this kind of work. I'm going to shoot through this slide here. It's just basically showing that, from the ground level, organ level, right up until precision medicine, we can actually use nanotechnology or nanomedicines. Interesting, from nano formulation, organ level, we're talking about oral delivery. So your typical oral formulations, how can we use nanomedicine to get better absorption of the neuroactive drug so that you can get more of the drug in the bloodstream, and from there more across the blood-brain barrier and more to where it needs to work at receptors for neuroavailability. Across biomembranes and tissues. Here we're talking about the blood-brain barrier, the ocular, ocular retinal barrier. In chemotherapy, there's a project that we have also in glioblastoma multiforme, as well as brain cancer, neuroregeneration. I talk about neurotrauma, spinal cord injury, peripheral nerve injury. And then the latest concept we're dealing with is this concept of nanotechnology combined with 3D bioprinting. So we can actually 3D bioprint organ or tissue with live cells, actually that can be implanted within, for example, in brain trauma, brain tissue trauma, where you can have a simulated or biomimetic material that can be printed with neurological cells and then implanted in the brain as a scaffold, and then hopefully you allow the body to regenerate itself to replace that tissue. And then precision medicine is obviously where we look at the RNA therapies, your gene expression, genetic therapies, and all of those technologies. So basically this slide is showing that nanomedicine starts from the organ level right up until precision medicine, and either step of the way, there's always a neurological application that we can use to actually get better delivery of drugs within the body. So our focus design these multifunctional nanosystems by combining the neuroactives, co-developing them with brain-targeted delivery systems to penetrate the blood-brain barrier. So this is a typical nanoparticle that you see here in the light blue color, the circular structure. And, we can manipulate the composition by have different types of polymers that we use. We can put various drugs on them and bound them to this nanoparticle. We can change the shape, as I showed you, and all of these properties come together, obviously target a specific application within the neurological space. When you look at typical drug delivery, or which the conventional tablets and capsules, some of these drugs still show very low bioavailability and not enough improved neuroavailability that I spoke about. They don't have good targeting, so you target certain receptors, or for example, if it's a certain cancer, you target the cancer cells only and leave the healthy cells alone. And obviously they have a lot of side effects. This nano-enabled approach improves all of this, and that's what we are getting at. So I have some examples to show, but I'm going to go, in the interest of time, I'm going to go very quickly through them. An application in neurodegeneration, an application in neuro-oncology, neuroprotection, so that's for more preventative, where we can use free radical scavenging properties of certain of these particles, and then neurotrauma and regenerative medicine is another application. Here, I'm just going to go very briefly. We designed these nanoparticles, which we call neurosomes, for Alzheimer's disease, where they target the amyloid beta plaques within the brain tissue to actually mop up all the excess copper and zinc. That's one theory that results in why the brain becomes neurotoxic, leading to Alzheimer's. The articles for this research is available. After the talk, you're only welcome to email me, and I can share all of the research on this. There's another example of where we use magnetized nanoparticles. We had magnetically active nanoparticles where we can guide nose to brain delivery. So minimally invasive, instead of implanting, into the brain. The first one, which I showed you earlier in a previous slide, was an implant inside the brain tissue, which, like I said, we worked with neurosurgeons and the Department of Neurology at WITS, where we had animal models designed to implant this. This one is a nose to brain. So you're looking at minimally invasive, where we use a magnetically guided system to actually push the particles towards different structures within the brain, use magnetism. And this is where we looked at, delivering iron oxide nanoparticles for the drug carmustine, which is used in brain cancer or GBM, and how we could get better, drug levels and guide it towards the brain tumor, for example, using magnetic properties. Here we looked at a neuroprotectant, which is your cerium oxide. So cerium oxide has been purported to be used for all sorts of things, for example, anti-cancer activity, cytotoxicity, antibacterial activity. One of the applications is neurotoxicity, which is kind of preventative neurotoxicity, and it acts as a free radical scavenger. The biggest problem with cerium oxide is there's no way of delivering it. If you take it via oral formulation, you're not going to get levels enough to actually behave as a free radical scavenger. So here's where we made these nanoparticles of plain cerium oxide oxide. There's no drug in this formulation, and that is then delivered, intravenously, gets to the CNS, and then that's where the ionic shifts happen within the serum oxide to then mop up all free radicals to kind of have a neuroprotectant kind of effect using this nanotechnology. Here's an application in, spinal cord injury, where we looked at, bridging the lesion site when after a spinal cord injury using a nanobiotract within a scaffold. So we created this artificial Bergman tracks, and these Bergman tracks has been inspired through embryological development stage, where you have the cells that are laid down during that stage for the spinal cord. So we thought, why not use that concept and then try to replicate that in an injured spinal cord, so that you could get the cells to start to recommunicate after it has been obviously a gap in the communication due to injury. So we've created the scaffold, we implanted it into a rat spinal cord, and some of the results are quite promising in that which we have, seen the rat actually regain some of its movement within its hind limbs. I'll show you 1 or 2 slides later on, but this is the kind of work in terms of spinal cord injury and the Blue Skies projects that we are working on. We have another one, obviously, in peripheral nerve injury as well, which is also an exciting project. Here I spoke about the 3D bioprinting. Basically, you can have, as you see there where it says matrix, we have these biomaterials or neuromaterials with these nanostructures that I explained, and we take them and we mix them with biological material, which could be neuronal cells, growth factors, and even drugs that may be anti-inflammatory, whatever it may be. And then we print them. We print them layer by layer. And, you could print all sorts of tissues and organs with this instrument, so that it can be obviously implanted in the body, and then allow, for with different growth factors to allow blood supply to move in, and then replaces tissue that has actually been damaged either through disease or trauma. Various chemical studies and testing is undertaken in our labs. I'm not going to go through all of this, all the physical, chemical, and mechanical testing to look at all different properties of all of these technologies that I've explained. So animal studies are also done here at WITS and in our central animal unit. We work very closely again with Department of Neurology and Neurosurgery at WITS University. This is the spinal cord study I spoke about earlier. It was the first category 6 study done at WITS, in a rat model. And then so in conclusion, colleagues, I mean, the largest challenge in this field is the ability to now balance all the performance objectives of these nano constructs, and how we integrate them with the biological, physical, and complexity. And, a large volume of research is on one direction in terms of how safe are they, the biocompatibility, etc. And I think a lot of studies have shown the safety and that kind of thing, but not a lot has shown the neuromechanical strength. How do we match the biomechanical strength of neurological tissue or of these materials? How do we promote healthy vasculature if we're doing the implant and tissue engineering part of things for these scaffolds? And then the last thing, the mimic the properties of natural tissue. When we're designing these nanomaterials, how can they become more bioresponsive, more stimuli responsive? How do they assimilate what your normal neurological tissue, at the same time delivering drug to those diseased or injured tissues? And finally, novel nanostructured bio inks is what we need for the 3D bioprinting application. That's the end of my presentation. I'm open for innovation, happy to work with neurologists and neurologists all over the show, because, I mean, our research is informed by clinicians. So you are a very important core component of, the work that we do. And that's my message here today. Thank you, Kirti, for your time.
Thank you. Yeah, I mean, it's absolutely incredible work, like bordering on, like, how did you imagine that this was possible? I did see a colleague of yours had presented on the study with the transected cord in the mouse, and
yes,
whatever it was that you did, that the mouse actually walked afterwards, was pretty phenomenal. That was like, oh, wow, this is absolutely incredible. So huge potential. I'm going to start with the questions. I'm going to invite anybody to please share either in the chat or to unmute yourself and to ask a question to any one of our panelists. I'm going to start with a question for you, Yahya. I think one of the challenges we have within the field is looking at the new therapeutics that are coming out for treatment of people with Alzheimer's disease. They're completely unaffordable, right? So how would these, like, new therapeutics, how do you ensure affordability, particularly in context?
So there's two kinds of way I can answer that question, Kirti. One is the affordability, I'm assuming you are referring to now the biologics and the peptides and protein-based molecules rather than your typical small molecule drugs. But mind you, for neurology, some of the small molecule drugs are still very expensive as well because they're on patent and this kind of things. So, the therapeutics research in the neurological space is very expensive research. And I think companies have to recoup the R&D costs, otherwise they will go bust. And, if they go bust, then obviously the tools that we need are not becoming available as a nice pipeline for the technologies. So the one is that the API or the neuroactive could be very expensive itself. And the other one could be the actual formulation development. So there's two components to it, So I think one of the focus is that how can we, because they're obviously on patent, there's nothing much you can do there. But when they come off generic, that is another discussion to have. But how can we use our drug delivery science and technology to obviously reimagine those products into more contextually relevant, applications? I mean, products. So, for example, injectables. Injectables are quite expensive because obviously it's cold chain, it's made in the sterile and manufacturing space, all of that, it comes into play. But then how can we pivot now from, for example, injectable formulations to microneedles, which is a topical formulation? So you do away with the cold chain, you improve the stability of the molecules, and then you have a much more accessible product. It could be more cheaper to actually implement. But the issue is that these molecules, because they need to be tested, in all sorts of animal models, preclinical studies, it's quite an expensive research. I think that's where the problem comes in and how we deal with that. I don't think that every single, unaffordable, or I don't want to call it the expensive drug is because of profiteering. I think that's some of the narrative that we normally do here. But I sit on a lot of bodies and fora where this is discussed. And if you look at the science involved in making a biologic, the starting material is so rare. The actual materials to scale up and the factories that you need to make these things are so complex. It does add to cost, but it does also have a moral and ethical issue. Like, I think, so for which type of patient is this? Those who can afford it will survive. Those who can't will left to the wayside. And I think, that's where my group is trying to look at how do we, find those niche areas where those very unaffordable products can be made a little bit more accessible. But for that to happen, we need the neurologists to work very closely with us to say, look, daily practice, I find this a problem. This is costing a patient prohibitive, et cetera, and that's how we work on it.
Sorry, I just, Tina also has to leave soon. So I thought, let me just give her a question quickly to answer. But thank you very much for that. I think there's a lot that we could debate then. That's probably a different session that we're going to have to do. Tina, thank you very much for joining us. I don't know if you want to potentially just answer maybe one question in terms of what do you think should be the priority? Like you mentioned quite a bit that we actually need to do, even in terms of, understanding context, the language. Like I said, working in a rural area, I realized the language was just, what we actually taught in neurology needs to be completely reconceptualized, actually, in a way. I'm building on what's there, but how do you think we go forward, or what the priority should be given brain health and given what we're trying to do?
So I wish there was a simple answer to the question. It is a huge challenge that we face, and I think to break it down into priorities, there are at least 4 components we need to take into consideration. Education, and the education across all levels, from population, within medical school, etc. And absolutely right, we need to look at a region appropriate form of neurology. It's not to say that the neurology is different, that we can treat things in a different way, but in a way that it is appropriate to understanding the context of our people, etc. So education, and then policy. So it is not enough to advocate for brain health, to talk about how important nutrition is for brain health, how it is important to reduce traumatism, if we do not work on all the different components. So we tell people, this is your brain health, this is what you have to do, but where are they going to, how are they going to do it? How are they going to afford the nutrition? It has to be from different levels. So the people need to understand that they have the rights to demand appropriate access to healthcare in general and neurological care in particular. But aside from them demanding it, the government needs to understand that it needs to provide these services, or at least work with different stakeholders to make these services available. So it's from lots of different angles. And then specifically within training, it is contextualizing neurology for the continent. One of the big challenges we face on the continent is that we are so scattered. We're not communicating with each other. And when we do, we find that, oh, things are not as bleak as we thought they were, or, oh, you know how to approach this problem that I didn't think of looking at in this way, etc. So I think part of it is getting to learn to talk to each other. So we learn to talk to each other and share our experiences, share our know-how, learn to talk to other people who are not neurologists. So not neurologists who are medical people, the language we use with them should be appropriate, because I think that this is the thing that has turned off most people from neurology. We start talking about our wonderful, fancy, and beloved neurology, and everyone just switches off. We have to learn to stop acting like it is that fancy thing, and it is, but we have to learn to speak about in different terms. We need to learn to speak about the economics of brain health, and more importantly, the economics of poor brain health. Because when we can speak about it in that context, and it's something we're never taught to do, we don't know how to speak in economic terms. The cost implications of, let's say, not taking your medications properly, the cost implications of taking these medications that are not produced on the continent. So it is amazing that we have these know-hows on the continent, and we need to breed them. We also need to get our governments interested in promoting these things so that, again, it becomes cheaper, easier, more readily available for treating our patients on our continent, rather than relying constantly on things coming from outside. So it's I'm sure I've left out one pillar that we're supposed to deal with. It is a very complex problem.
Yeah, it's complex.
Priority is getting to talk about brain health and getting everyone to understand that without brain health, there is no health without brain health. There is no economy without brain health. There's no productivity without brain health. And that is how we get everybody on board with us on this journey.
Thank you very much, Tina. I know you have to go for another meeting, but thank you very much. We will be in contact, and yeah, we'll definitely look at what we can do going forward. Thank you. Okay, I'm going to go to other questions. I know Alfred, do you want to unmute yourself and ask, Alfred?
So I was going to not ask a question, but I think I mentioned already on our chat, say that there are training programs in Central Ghats actually produce its first batch of neurologists, one
amazing.
for Congo Brazzaville. That's the contribution I wanted to make, and to continue from there to say that yes, these things are happening. I mean, Tina talked about a continental training program. I think that national neurology training programs already take into consideration the needs of the country. And we need to recognize this. I mean, I know several of them, having been around, moved around and teaching courses around the continent. I think it's not as bleak as she mentioned before just leaving. It's not as bleak as we see. Sometimes we don't see what we're doing because, like we said, we don't communicate enough. Talking about reaching out to primary schools, we started doing that, secondary schools, about brain health in 2008. Brain health, when he was president of the taking over from Johan Arley. So even though the WHO just got on board recently, the World Federation of Neurology has been working on this concept for a long time. In fact, the World Neurology convinced the WHO brain health concept and the mental health concept, if you look at the World Health Organization Mental Health Report 2002, it shows that not much has been achieved, even though a lot has been invested into that program. And my suggestion, and I've published this in an abstract somewhere, is that the mental health approach is stigmatizing, is self-limiting, and is limited in scope. And I suggest that mental health is part of brain health. And if everybody embraces brain health, we would make much more progress than we have done with the small, limited mental health concept, which is also very stigmatized, because the concept of mental disease or psychiatric disease is more stigmatizing than neurological or brain disease. So to say that, I'll congratulate a colleague from Colombia for sharing those thoughts on dementia. We share the same issues, and I think working together would help us. I don't know when she'll be returning to Colombia. It was very attractive. It sounds like we should all go and work in Colombia.
It was.
Really,
We're all
really
coming, Alejandra.
Exactly. So we are ready. And then a comment to Yahya. Congratulations, fascinating work. And I'm really glad to see that Africa is producing novel nanotechnology and other technologies that we can export to the rest of the world. We neurologists and basic neuroscience people and translational neuroscience people in Brain Research Africa Initiative are available. Yeah. We are available. I have a neuroscience lab in the Faculty of Medicine where we do some animal work with animal models, and we're using extracts from our African traditional pharmacopoeia to look for medications for Alzheimer's disease and other neurological problems. And I think working with your lab will help us. And in Brain, our organization, we have a department called Brain Innovation Labs. So I think that we will connect, and Kirti will help us to connect. Neurologists from Brain are available. And it may interest you to know that Brain has moved from Central African countries to now about 15 countries. Our networks are growing and paralleling with Kirti's brain health networks. So I think that this timing is really critical for us in Africa. We are getting to know ourselves. We are beginning to organize our networks, and the networks are beginning to network with other networks, and that's what the brain is all about. So I'm very, very excited to learn about what you're doing. And thanks again, Kirti, for building these connections. Very exciting work.
Thanks, Alfred. I like the analogy of we're actually following the brain networking and the networks. Yahya, you wanted to respond to that? There was also a question for you regarding neurosomes. So when you respond to that, and also what are neurosomes and what is the real potential in Alzheimer's disease?
Yeah, thanks. Prof. Alfred, more than happy to obviously, fit within your network and see how we could have some North-South collaboration in terms of, the kind of work we do, and answer some of the bigger questions. You can only answer those with bigger teams, and I think that's what's needed. In terms of the neurosomes, so the neurosomes is obviously similar to the liposome structure that I think most of us are probably familiar with now since COVID-19 vaccines came about. The mRNA vaccines with lipid nanoparticles. I'm sure you've read that in the literatures, when it came out. So the neurosomes, we have been working with this obviously before COVID-19. This is a work that we've done in about 2010 or 2011. Where we have these neurosomes are liposomes, or neurological lipids that have neurological properties in terms of its responsiveness. So it's actually, it aligns to what the neurospace may be in terms of its pH, in terms of its physiological makeup, and that's how it becomes the neurosome. What we're using this for is obviously to encapsulate drugs within these neurosomes and then target them to various structures within the CNS. For the brain application, for what we saw in Alzheimer's, that was actually, the theory which was a standing theory at the time, was excess copper and zinc in the neurological tissue causes this neurotoxicity, and it causes this amyloid beta plaques to form, and that's what's one of the theories responsible for Alzheimer's disease. So we thought, why not have these neurosomes that can go up and chelate? So chelation is a chemical reaction where you can bind all of the zinc and the copper and kind of mop it up from, it's kind of spongy, substrate it out of the neurological tissue, so it does not interfere with the neurologic tissue, and hopefully that could improve the Alzheimer's condition. One thing that why we need partnerships is that because we need to move towards the preclinical stage now in terms of using a challenge model, in terms of using a diseased model for Alzheimer's. That's why colleagues who do have these models within their labs, either in larger animal models. I mean, we do a lot of work on mice and rats and rabbits, but we need to move to now, obviously, your non-primate models and the bigger, larger models. And for that, we do need collaborative networks that are quite strong so that we can replicate the Alzheimer's, for example, and then treat and see what goes on.
Thanks, Yahya. I think there's quite a few people from different fields and also different countries who are actually looking at research. Can they contact you if they are interested in exploring this relationship? And if so, could you put your email in the chat box, perhaps?
Yes. No, most welcome, Kirti, and I think I appreciate innovation can only happen with partnership, and I think that is something we encourage, and we're happy and open for innovation. So I'll do that. Thank you.
Perfect. Thank you. Any other questions? Alejandra, I have a question for you, or am I not seeing a hand? Or please just unmute yourself if you do want to ask, because I can't see everything. Alejandra, I have a question for you before we end, actually. I think one of the challenges also, like you said, like I said, there's all these different factors. And one of the things, though, is that we do have countries with high levels of food insecurity as well. So how do you think that should come into our approaches to brain health? I know you mentioned it as a socioeconomic factor, but I do wonder if within brain health as a field, we need to focus on that.
Oh, for sure. That's a very complex question, Kirti.
It's a very complex question. I agree.
For sure, I think Tina said something about that, like, how can we advise for, good food, healthy food, the typical Mediterranean diet, if we don't have the resources to have that kind of healthy diet good for the brain. So it's very difficult, and I think for sure it goes beyond my neurological expertise.
Okay.
Yeah. I don't know if you have any approach for that. It's very difficult.
No, it's difficult, but it's one of the things I think we need to, as in neurology and even in brain health, to start actually focusing on. Andre, do you have any last comments or thoughts?
It is not even difficult.
Oh.
Do we have
Alfred? Okay, cool. Alfred, excellent.
Let me encourage us. It is not as difficult as that. It may interest you to know that in December I'll be flying to Uruguay to teach a course at the university there with Maria Castello on neurodiplomacy. It is not difficult. It is difficult because we stay within our neurology confines, and we have engaged. Oh, I'm breaking. Sorry. I think it's possible. Let me summarize it in 1 second. It is not that difficult. It is possible. Diplomacy, neuroeconomics, and neuropolitics. I'm a scholar in that. I'm learning a lot.
Oh, and yeah, we've lost you, Alfred.
Sorry.
Okay.
Can you write? Because I really want to know.
Do you want to try again, Alfred? Or no, we've lost him now? Yeah, lost him.
Oh, can you hear me?
Yes, we can now.
Yeah, just 1 second. It is not very difficult. It is possible. But what we need to do is to learn new skills, and it is doing that. We need to learn neurodiplomacy. I'm going to neurodiplomacy for the second time in a course we do with UNESCO. So it's possible to engage governments. It is possible. We are in that business. For the past
Great.
25, 30 years, Brain has been doing that in Cameroon and Africa and with the AU. It's possible. And then with the Atlantic fellows, I know you have a lot of skill. So I think that we'll be able to do that.
Excellent, for sure. That's a training I need to take.
Yeah, no, thanks, Alfred.
Okay,
I think we
I'll
do
let you
all
know.
need to hear that. Andre, do you have any thoughts from the session?
Just to say thank you again for bringing that together. It was really a beautiful compendium of lectures today and very thought-provoking. And I really like that what Prof. Alfred said with this networking analogy. And I think that is going to be the strength going forward, and that must come out of series like this, and really to encourage you to continue doing this and building on it, bringing, these thoughts together and these people together. So especially to have now Yahya on today, absolutely fascinating. So there's lots of beautiful, avenues to pursue. So thanks, Kirti. That's all.
Okay, perfect. Thanks, Andre. Tina, I see you joined us again. Do you want to add anything before we close?
Thank you very much for the opportunity. I think the more we talk about brain health and the different components of addressing the issue of brain health, how we maintain brain health, and how we treat neurological diseases, I think we will, small steps at the beginning, but all together we will be able to promote brain health on the continent. And as Professor Jamshi said, it is possible. It may not necessarily be easy, but it's definitely possible. And we really don't have the option. We have to do all of this to promote brain health on the continent. Thank you very much.
Thank you. Thank you all. Thank you, Tina. Thank you, Yahya. Thank you, Alejandra, for your insights. Thank you, Andre, for helping to make this happen. And thank you, Alfred. We really do value your insights. Thank you all the participants for your questions and for being so engaged in this. The last one for the year will be, I think it's the 4th of December, but anyway, it's the first Tuesday on December. And it will focus on what we can learn from HIV public health initiatives to actually support brain health. So what do we learn from movements that have actually been successful across the continent in different contexts that we can actually use as we build this brain health movement. So I hope to see you then as well. And I will be sending out a short survey form as well. I hope that you can fill that out for me. And thank you all for joining us. We'll see you next time. Thank you.
Thank you. Bye.
Thank you. Bye.
Thank you. Bye.